Yes, we are.
Okay. Thanks, Jeff. It's great to be able to talk to you folks about two recent investigations that the Heart Center is involved in. Last week, Dr. Zlatko Pozek talked about the Titan trial, a project dear to his heart, in which patients are randomized to surgical therapy versus watchful waiting when they have an ascending aorta that measures 50 to 54 millimeters. This is an area that's of unknown import, and so it's a very interesting trial. And if you haven't seen Dr. Pozek's presentation, it's on YouTube. This week, we're talking about ticagrelor reversal in conjunction with a recent trial. So it's about bloody time that we had something to reverse ticagrelor, and I'll tell you why. So this is the ADP molecule. You might remember that from organic chemistry. And this is ticagrelor. You'll see that they're almost identical with some added side chains. And that's why ticagrelor binds very well to the ADP receptor on the platelet. Ticagrelor is a wonderful drug. It's absorbed quickly. It reaches its peak concentration very quickly. It's very effective quickly, which is ideal for many of its indications. In contrast to the other P2Y12 receptor antagonists, however, this is a reversible antagonist, which makes all the difference when designing a reversible agent. So casting our minds back to this is the platelet, of course, the orange thing, and you can see there's multiple receptors on the platelet surface. Some of them you recognize, thromboxane receptor that's inhibited by aspirin, the G2B3A, which works with integralin, and of course the ADP receptor that works with all the ADP receptor antagonists, including ticagrelor. Well, why are we talking about ticagrelor? Why is ticagrelor increasingly popular? It's because there's been several recent trials that have been presented within the last 1 or 2 years. This is one of them, the Plato trial, which investigated patients with acute coronary syndrome, and they randomized the patients to either aspirin and Plavix or aspirin and ticagrelor. And you can see that the composite endpoint of cardiovascular death, myocardial infarction, or stroke was significantly better with ticagrelor versus Plavix at the end of 12 months, with a very tiny cost and more bleeding. Similarly, the Themis trial, again published in the New England Journal of Medicine recently, looked at a different patient subgroup. These are patients with stable coronary disease and diabetic, and randomized them to aspirin only or aspirin plus ticagrelor. And again, we see a difference in the major composite endpoint of cardiovascular death, MI or stroke. And this time there is a little bit higher difference in the major bleeding cost because aspirin alone is fairly safe. And then finally, another indication has come to light with ticagrelor, and that is in the setting of acute ischemic stroke, or TIA. Again, randomizing these patients to aspirin versus aspirin plus ticagrelor. And again, we see the probability of stroke or death significantly different, and clinically significantly different as well. And again, a small difference in bleeding. So this is becoming a bigger part of our armamentarium for these thrombotic disasters. And you can see that it's now achieved indications for these things. Let me then sidestep for a moment and talk about a recent case that presented to the Brunswick Heart Center. This is a 69-year-old gentleman who presented to his local hospital with a non-ST elevation myocardial infarction with a troponin of 803, inferior ECG changes. They did actually 2 echoes at his home hospital because he had a fever and had a positive blood culture. They wanted to rule out endocarditis as well. And his echoes didn't show any evidence of endocarditis, but did show a moderate aortic valve stenosis. He had continued off and on chest pain in his home hospital with ECG changes while waiting for transfer. Came down on a Sunday went to the cardiac cath lab, which demonstrated left main and 3-vessel disease, fairly well-preserved ejection fraction, and continued to have pain in the cath lab. At that point, cardiac surgery became involved. The consensus was to insert a balloon pump and see if this pain would settle, which it quickly did. He was transferred up to the coronary care unit for ultra-urgent surgery the next day with a plan for 4 bypasses and aortic valve replacement, noting that he was on aspirin and ticagrelor from his home hospital. The next morning, he was down in the cardiac surgery suite, looking pale and unwell, which was different than what he had looked in the cath lab. The cardiac anesthesiologist noted he was unstable with the induction and did not respond to the usual tiny doses of inotropes that they often use during induction. This, followed by insertion of the TE probe, demonstrated cardiac tamponade, and a lactate came back at the same time of 10. So some time between his cardiac cath and his arrival in the cardiac operating room, he had slipped into cardiogenic shock. That altered the order of things in the operating room a little bit, and we did immediate median sternotomy and a pericardiotomy, which released his tamponade. His cardiac index rose from 1.2 to 3 within 5 seconds, and things stabilized nicely. But unfortunately, that pericardiotomy also revealed that he'd had severe acute pericarditis with a large inflammatory problem inside his pericardium. Surgery continued on with 3-vessel bypass surgery, a tissue aortic valve replacement, and partial pericardiectomy. And we certainly noticed a severe vasoplegia that required multiple medications to control and torrential bleeding. Well, should we have been surprised by the torrential bleeding? The answer certainly is not. Although ticagrelor and aspirin in the trials, such as Plato, didn't really result in major problems with bleeding. There was only 11.6% major bleeding event in Plato, but of those 11.6%, only 5% had fatal or life-threatening bleeding. So a tiny percentage really had very, very severe bleeding. But also in Plato, it's clear that those patients that had to have ultra-urgent or emergent surgeries while on the ticagrelor and aspirin had a much different outcome. Nearly 2/3 of those suffered fatal or life-threatening bleeding perioperatively. So we should not have been surprised by that amount of trouble. And ordinarily, when patients arrive in a heart center in acute coronary syndromes with aspirin ticagrelor on board, our strategy is to delay as much as possible, usually 4 or 5 days, wait for the ticagrelor to wear off. But sometimes, as in this case, we couldn't. The balloon pump was in, the patient wasn't really stable enough to wait for 5 days with a balloon pump in. It's difficult because our ordinary mechanisms of giving platelets to correct the platelet problem are essentially useless in this scenario. As fast as the platelets are given, their aggregation is altered and their reactivity becomes 0. In fact, during this case, we gave 5 units of platelets, drove his platelet count to 300. None of those platelets worked on platelet function assays intraoperatively. What we really need is a reversal agent, which is what we've been involved with. And in the Reversa trial with bentracimab is the name of the agent. And you may have seen earlier publications in the New England Journal of Medicine for the phase 1 and phase 2A and 2B trials involving this substance in healthy volunteers and elderly patients and patients with high doses of ticagrelor. It showed in those patients immediate and sustained reversal of ticagrelor's effects. Very, very impressive. And so this has been designated by the FDA as a breakthrough therapy and given prime designation by the European Medicines Agency as well. So to play with this a bit, so one understands the ADP binds to the P2Y12 receptor on the platelet, activates the platelet. Ticagrelor binds also to that same receptor and displaces the ADP such that now the platelet cannot be reactive. But you'll see that this is a reversible binding, and that is the key. So if you could design something that grabbed the ticagrelor while it was off the receptor, that would allow ADP to rebind and make the platelet more receptive. And that's in fact what this substance does. It's a monoclonal antibody that binds the ticagrelor and then is excreted from the system. The design of this trial has been, it's a global multi-center, 3 continents are involved, multiple countries. There's 2 arms to the trial. A surgical arm, that is patients that require ultra urgent or emergent surgeries while on ticagrelor, and a bleeding arm, patients that are on ticagrelor are having a major bleeding event. It's a prospective, open label, single arm, uncontrolled trial. At the time this slide was made, there was 13 sites, mostly in the United States. There's now over 20, and there's certainly a lot more than 50 patients dosed now. So this human monoclonal antibody fragment is delivered intravenously, and its goal is to recover platelet function so that the bleeding stops in people that have activated major bleeding, and it allows people to have urgent surgery or interventions in those that are on ticagrelor that would otherwise have very dire bleeding complications. And when you look at the phase 1 trial, if this is the normal platelet reactivity up here, once you give ticagrelor, it's down there, 0 platelet reactivity. If you follow that and give placebo, that black line is what happens to your platelet reactivity. For 24 hours, it's essentially paralyzed. If you give this new agent, it immediately reverses that. You achieve normal platelet reactivity, which is sustained for at least 20 hours in this phase 1 trial. And the cost of that administration is very little. The side effects, the treatment, emergent adverse effects, and serious adverse events was very low, very safe, no safety signals. And then the FDA required a second phase 2 trial, which examining in particular the higher dose of ticagrelor, making sure that it was effective in that dose range, and also looking at older and elderly patients, 50 to 80 years old. So phase 2 trials concentrated on that. And again, you see similar responsiveness to this platelet reactivity with the elderly patients, again, achieving a very quick response and sustained, and similar with a high dose of ticagrelor reacquiring platelet function, and it's being sustained for 24 hours. So very impressive, very, very hopeful. And again, in the phase 2 trials, still no safety signals, minimal side effects. Phase 3 Reversal trial, which is a trial that we've been involved with, has now been ongoing since mid-2020. And it is, as I mentioned, an open label single arm trial. And the data review now is beginning to approach. The interim analysis of the surgical side, the surgical arm of this trial is now underway. This trial was basically an important point here is that for the surgeon involved in these trials, we had to adjudicate or assess bleeding intraoperatively and justify our decisions using the Gusto bleeding trial measurements, and then that's centrally adjudicated. There is also a primary reversal endpoint using the platelet function assay. So there's 2 primary endpoints with platelet function assay and bleeding. I think I talked about that. There are other clinical endpoints, such as the time to effective hemostasis, hospital stay and ICU stay, and how much blood they get and what type of blood products and so on. So these also are being examined. You might imagine that when we were contemplating this trial, we were very cognizant of the concerns that might arise regarding thrombosis. So if you're taking a patient, for instance, with ACS, and you're giving a medication that stops platelet inhibition within 5 minutes, are these patients going to go on an infarct again? this would be a major concern. So this is something that's very carefully assessed during this trial. And from our perspective in the surgery, we have gotten around some of our concern regarding this by administering the monoclonal antibody very close to the onset of cardiopulmonary bypass. So generally speaking, we were administering the drug while taking the internal thoracic artery down from the chest wall, which would be shortly followed by the institution of cardiopulmonary bypass with full heparinization. They had to be, of course, adult patients. They had to have been on ticagrelor to qualify for this trial. They had to be not just urgent coronary surgery, but ultra urgent, in the sense that we didn't feel it was wise to wait for the 4 or 5 days for ticagrelor to wear off. This is patients that we really wanted to get to the operating room. Patients that are pregnant could be enrolled. I'm not aware of any patients that were pregnant. Certainly renal patients were candidates. Exclusion criteria were if you're on other antithrombotic agents, other antiplatelet agents, anticoagulants other than heparin, all those things would exclude the patient from participation. And certainly if the patient had received medication to reverse anticoagulation, those also would exclude the patient. So in summary, this was a multi-center open label prospective single arm trial, and the surgical side is now finished. The bleeding arm is still ongoing, a little bit more difficult to recruit to. The results are being analyzed, and I'm not at liberty to discuss that much further than that, but I can tell you that you might expect information fairly soon. There's the Gusto scale. So getting back to our case presentation, severe vasoplegia, torrential bleeding ongoing. What happened? Well, we didn't give this bentracimab because the trial at that point had been finished and we did not have access to it. So that's why we couldn't enroll him. We spent 4 hours in the operating room waiting for bleeding to calm down. It had calmed down enough. I thought that it was safe to move to ICU, where over the next 4 hours, the patient bled another 2 liters of blood with 4 nurses continuously stripping chest tubes. So I know that those 4 nurses saved this patient's life. If they had not have done that, he would have reaccumulated his blood and tamponated it yet again. His course post-operatively has not been straightforward. He's developed acute kidney injury, not to the point of needing replacement therapy, but it's been a struggle in that perspective. He's developed a peripheral myopathy that neurology are investigating with not much in the way of answers just yet. They think his brain is okay, but they're not sure about his peripheral nerves, and they're doing a bunch of different investigations. He's developed a GI bleed. And last night became very short of breath during the middle of the night. I'm not sure yet why. I'm afraid that he's had a pulmonary embolism because I stopped many of his things when he had the GI bleed. So that's something that I have to investigate this morning. So I've decided I'm going to add this to my list of things I hate. Besides vandalism, irony, and lists, it's surgery plus ticagrelor. Thanks very much. If you have any questions, I'm happy to entertain them.
Excellent, Craig. If you want to stop sharing the screen, then we get everybody back on online. I like that last slide. Just hit the red button. It should be green or red. It should be red. Stop share. Perfect. All right. So any questions from the audience? I certainly do. A couple of questions come to mind in my thoughts is one, you obviously said that maybe we'll have some potential answers from the trial soon, but does that mean there'll be a potential use clinically soon? And do you have a sense of what that would mean? So is it 1 year, 2 year, 5 year, what's sort of the outlook as the first question? And the second question, while you showed evidence that clearly ticagrelor appears more efficacious, why are we not using more ticagrelor than we are currently? That's one part of the question. The second part, will this agent change that pendulum dramatically?
Well, this trial only had 100 patients in each of the surgical arms. It's not going to be enough, I think, to hang our hats on, especially from the point of view of concerns about safety and so on. So I would be very unsurprised if there isn't a phase 3B trial with larger numbers, bigger trial. So we look forward to that. The results haven't been analyzed. They're not published. So I can't tell you very much more about that. I can tell you that in our experience, and I know that you can support that, it appeared to work very well.
Yeah, I agree.
In the patients that I had, it was very, very, very impressive. It was like the patients had not received any ticagrelor at all. So I was very pleased, and we did not have. I can say that in our patients in our center, we had no complications, and the bleeding was not an issue. So this was very impressive. Will it change the uptake of ticagrelor? I think the uptake of ticagrelor is going to happen anyway. I think we're going to see more and more, and certainly in other provinces, it's a very common thing. The cardiac surgeons are having to deal with this in a much more frequent manner, and it's a much more common drug in the CCUs. So I think that New Brunswick has been a little bit slow on the uptake, and we're going to see more of it. And with it, if this pans out as a true reversal agent that's safe and effective, that'll even hasten the process. Yeah, we really do need it, because it's, as you can see, it's a very effective drug, but it's a very dangerous drug.
If we have patients here in St. John that are medically bleeding on ticagrelor, don't need surgery, are they still possible to enroll in our trial? That's just something for the clinicians here in St. John. So if you have clinical bleeding in someone who's received ticagrelor, are we still eligible as a center?
Yeah, certainly we've been very strongly encouraged to do so. From a perspective of logistics, it's very difficult to do that, because apart from the ACS patients that primarily come from other centers, there's not a huge burden of ticagrelor use in this center. So they come very few and far between, and to keep our sort of pharmacists on call 24 hours a day for our research pharmacists for this and the research team, it's just probably not tenable to do this.
Mm-hmm.
It requires, I think, a bigger center in a patient population that is more susceptible to being on ticagrelor.
Correct. I can see why the surgical arm was able to close so quickly. I mean, for us, it was relatively straightforward. Ticagrelor within 48 hours surgery. This is pretty standard ACS interventions for us.
Yeah, exactly. Yeah, I think that even surprised the sponsor of the trial how quickly the surgical arm filled. So I think that demonstrates, something about the need for this drug.
100%. Any other questions from the audience? Any on the chat? I don't see anything in the chat. If that's the case, I will thank you, Craig, for the rounds this morning, and see you next time, everybody. Have a good day. Thank you.
Thank you.